Good morning for some of you. Good afternoon, good morning for some of you, even good evening. Ken Mayer here from the Harvard CFAR, and with my co-facilitator, Patrick Sullivan, really want to welcome you to the antiretroviral prevention science sessions that we have on a bi-monthly basis. We'll wait a minute or two before we get started, just to give people a chance to join the Zoom. We're very fortunate to have with us today Doctors Doug Krakauer and Alex Keroulian, who'll be talking about building clinical workforce capacity to deliver PrEP. As a reminder, please, if you have questions, please submit them in the chat. We will have time towards the end of the hour to answer your questions, and we welcome them and look forward to them. This is an activity of the National CFAR program. It's a joint interaction between the Emory and the Harvard CFARs. We'll give it another minute or so before we get going. Thank you all for participating. Just watching the cadence of the people who are entering the Zoom. We'll give it just another minute and we will start. Hello, everyone. This is Ken Mayer from the Harvard CFAR. Very happy to welcome you today on behalf of myself and Patrick Sullivan, co-facilitator of this inter-CFAR antiretroviral prevention working group. We are very fortunate to have with us today Drs. Alex Keroulian and Dr. Douglas Krakauer to talk about building clinical workforce capacity to deliver PrEP. Dr. Keroulian is an associate professor of psychiatry at Harvard Medical School, the associate director for community psychiatry at Massachusetts General Hospital, and the head of the Fenway Institute National Center for LGBTQIA+ Health Education, who runs our Division of Education and Training. Dr. Krakauer is an associate professor of medicine at Harvard Medical School and Beth Israel Deaconess Medical Center, where he is an infectious disease attending. He's also faculty at the Harvard Department of Population Medicine and is an associated faculty at the Fenway Institute. So without further ado, Alex and Doug, please take it away. And thank you for coming today.
Thanks so much, Ken. It's really a pleasure to be here and to speak with Dr. Keroulian on this topic, of which he's a national expert. And we're going to do a tag team. I'll talk for the first half, we'll talk for the second half, and we'll be really happy to welcome questions at the very end here. My disclosures. So just to set the background in terms of where we are in terms of PrEP use, it's clearly a very potent intervention, but it's being used least by those who could benefit the most. A few years ago, the CDC estimated that the risk of an HIV diagnosis among several groups of men who have sex with men, based on their race and ethnicity, African American, Hispanic, or white, had really high rates of new HIV diagnoses if more wasn't done in terms of effective HIV prevention, with striking rates as high as a model study showing 1 in 2 African-American MSM could have an HIV diagnosis. So clearly we need to do more to prevent that. But PrEP coverage with some recent estimates is far below where it could be, and there are striking inequities, with Black MSM only having 8% of the population who could benefit from PrEP actually getting a prescription, 14% for Hispanic MSM, and higher for white MSM, but still nowhere near what we want as the ideal. And there are additional populations such as young people, cisgender women, transgender people, and people who inject drugs where we don't have as much data. There's clearly underuse in all these populations, but we need to figure out a way to scale this up. And because PrEP is a prescription-only medication, providers and the healthcare professional workforce is a really key piece of the puzzle, which is why we're having this topic today. And unfortunately, the status of routine PrEP discussions, which is important for getting their prescriptions going do not happen routinely in primary care settings. And the CDC has recommended that since 2017 with their PrEP guidance that clinicians discuss PrEP with people who are at increased risk for HIV. And then more recently in 2021, they upped it to say, really, we should discuss PrEP with all sexually active people, both adolescents and adults. So it's a big ask of providers, but an important one. And so we need to figure out ways to support providers to have these discussions more routinely. But we have a long way to go. One study from the VA showed that almost all the PrEP discussions were initiated by patients and not providers in their system. So we need to not just get providers ready to prescribe it when asked about it, but also be more proactive. But unfortunately, we know how busy providers are and they have tons of barriers to doing this, as we'll talk more about. And a quote from a nurse practitioner to this effect: I think in the perfect world, we have more time to be in a room and really kind of get into discussions with patients about PrEP. But in the real world, where your boss is telling you you have 15 minutes to see a person, it's just not practical. So taking a big step back about all the barriers healthcare providers might face to discussing and prescribing PrEP, there's a lack of training, which we'll talk about today. Providers are not routinely trained in sexual health to the degree we need, and certainly not in PrEP in many clinical settings. There's something called the purview paradox, where primary care providers think that using HIV medications for prevention is something that specialists, like HIV specialists or infectious disease doctors, should do. And those specialists feel like most of the people who would benefit from PrEP are in primary care settings. So there's been a challenge in getting people by specialty to kind of own this as something that's within their purview. There are many competing demands. There are lots of preventive care issues that are not just around sexual health that have to be juggled. Providers are not necessarily trained or skilled or comfortable engaging in HIV risk assessments to see which individuals and at which times in their lives would be most likely to benefit from PrEP. So they need more training and support there. There's stigma and implicit bias that has been demonstrated amongst providers in terms of who they discuss and offer PrEP to that unfortunately exacerbate inequities. And there are workforce limitations. Only a certain number of healthcare professionals out there to do this. And with the pandemic, there's even more shortages. So all these things make it especially challenging. So what are the solutions? There are a couple of big categories, I think, that we need to think about. One is more effective trainings to get people prepared, excited, and motivated to discuss and do PrEP as part of their practices. Clinical decision support so that providers who are eager to do this have all the tools they need to make this as easy as possible. We need to think about a broader range of healthcare providers who would be trained and prepared to do this instead of just maybe primary care providers and infectious disease specialists. And then think about meeting patients where they're at and making PrEP available in alternative settings that are not just traditional clinical and primary care settings. So I'm going to talk mostly about the latter three, and then Dr. Crowley mostly about the first one, but together we'll cover most of these topics. So just briefly in terms of clinical trainings, what are the evidence-supported strategies that can train clinicians in PrEP? One of them is called academic detailing for PrEP, which is an educational outreach technique that's one-on-one based on social marketing principles. It was originally developed for pharmaceutical representatives to try and get clinicians to prescribe their brand name medications over others, but the principles work for evidence-based practices as well. And so New York City had a large academic detailing campaign where they tried to engage providers in PrEP. They sent out about 4 or 5 detailers to over 1,300 providers all across New York City and many clinical sites. And this campaign of meeting people in their offices and giving them these quick bursts of individualized education had a 12% increase in first ever PrEP prescribing among providers. So this clearly can work and needs to be scaled up. There's also telementoring or PrEP echo type projects where experts can be in the comfort of their own setting, but then reach people all across the country and the world using virtual technologies. And some studies have shown this is also associated with improved provider knowledge of PrEP. If people feel like their concerns about doing this are addressed, and it increases their prescribing intentions. So Alex will talk more about that at the second half of the talk, but these evidence-supported strategies absolutely are critical to scale up. So what about clinical decision support for providers who are on the front lines but may not be as comfortable with PrEP? So electronic health records are a really important part of any clinical practice nowadays, and providers spend most of their time with the third person in any patient encounter in the room, which is the computer. And so in other parts of preventive healthcare for primary care, we use clinical decision support to prompt providers to do risk assessments for things like cardiovascular disease prevention, and then set it up where they can very easily offer things like preventive medications like statins to prevent adverse cardiovascular outcomes. So here's an example from a screenshot from an EHR where a provider can be shown that a person's at increased risk for heart disease. It can give them a risk score for their risk of a stroke or heart attack, and then actually give them buttons to press to actually bring up statin medications. So we thought, what about this same kind of process for things like PrEP? And a quote from a physician in Alabama as part of a qualitative study we did to try and understand whether providers would want this kind of clinical decision support for PrEP. The quote is that having an automated process like this makes it, you get the muscle memory, you get into the habit of doing something, and then it becomes something routine for you. So people felt like this could be something that would help their PrEP practices. And at some point, if they got really good, wouldn't even necessarily need all the support, kind of like taking the training wheels off over time. So my colleague Julia Marcus and I have independently done some work with electronic health records data to see if you can build prediction models to identify people most likely to benefit from PrEP discussions and use as part of routine primary care. And she did some work at Kaiser Permanente, an integrated healthcare system in Northern California. And they used data from almost 4 million members of this Northern California organization. And they used some machine learning methodologies called the lasso regression to use a bunch of years of EHR data to try and predict who would have an incident HIV diagnosis in the cohort, and then build a model that could be used in a prospective way to improve clinicians' practices. What they found is that the area under the curve, which is the predictive performance, was quite good at 0.84, with 1 being perfect and 0.5 being just as good as a flip of the coin and not helpful at all. And they also found that a full model that used lots of different types of EHR data outperformed simpler basic models that would rely on the kinds of traditional HIV risk factors, such as just someone's sexual orientation or whether they've had an STI in the past, and that the fairness was improved, particularly for Black patients, by using a more comprehensive set of data. So based on this and similar work that our group has done in Massachusetts, including help from Ken and my colleague Mike Klumpus at Harvard Medical School, we've moved forward with this idea of seeing, can we build decision support that uses these models to help providers in their practices? And just to give you a sense for Dr. Marcus's model, the final model that they used included a bunch of categories of EHR data, which can both look at sexual health and substance use type domains, but also things like demographics that may relate to the social determinants of health and HIV risk. So the final model used a bunch of demographic and socioeconomic data can be gleaned from an EHR, social history such as sexual orientation and sexual activity, a bunch of laboratory tests and results around STI care and substance use, medications such as penicillin, G-benzathine, which is pretty much exclusively used for things like syphilis treatments and might be markers of HIV risk, and then ICD codes that providers put in, such as high-risk sexual behaviors. So these models have good predictive performance, and the USPSTF has looked at ways to improve PrEP prescribing, and they have a draft updated recommendation around PrEP. The original recommendation for PrEP was a grade A, the highest grade, saying that the benefits outweigh the risks, but they're updating their recommendation from 2022, and it's still in draft form. But the draft, which is available for public comment, mentioned that there's some benefit for having instruments or predictive models like this that are accurate for predicting risk of incident HIV infection that could help providers think about decisions regarding the eligibility for PrEP, and that there were 2 models in general populations that had good predictive performance. And they cited Dr. Marcus's model and the one that we made in Massachusetts as 2 examples of this that could be moved forward. But they appropriately cite that we need to verify whether these models that are accurate actually have impact in real clinical settings. And that's the next phase of research for clinical decision support. And Dr. Marcus and I have a study with Ken and others called the PREDICT study, which is funded by the NIH to look at whether you could use these decision support tools as part of routine care to improve PrEP discussions. And so we've built a tool very similar to the one Julia had, where we have implemented this in OCHIN, which is a network of community health centers that serves mostly uninsured and low-income people. They serve over 6 million people. And we developed and validated a local tool using the local EHR data from all the sites, and they share a common EHR, so it's a really powerful way to develop a model that has national scope. And so we use retrospective data from almost 2 million OCHIN patients to develop a model. And then we built a stakeholder-informed decision support tool in their EHR, which is Epic, the most widely used EHR in the country, that embeds the tool. And we just recently are almost finishing a study evaluating the feasibility, acceptability, and the early impact on PrEP discussions and prescribing of using this kind of tool. So let me walk you through this, because I think it's kind of a prototypical approach to how you might do this in any healthcare setting. So we built what are called best practice alerts. They're sort of pop-up messages if the model identifies someone who might be at increased risk for HIV and benefit from a PrEP discussion. So this flags providers to think about talking to their patients in routine care about PrEP. We have what's called a smart set, which actually gives some scripted language that providers can use. If they're not comfortable with their own language, they can actually kind of get the muscle memory with some scripts that actually pop up right on the screen that they can use in real time. And we tried to make the ordering of labs and medications as simple as possible. So it's pre-populated boxes that the providers just have to co-sign and have a click of the button. And we also have pre-populated diagnosis codes and documentation for clinical notes to keep the bar really, really low. And just to walk through, one of the things we tried to be intentional about was making the language we use patient-centered, because we know that stigma and patients feel judged by providers around sexual health in many jurisdictions. And we wanted to try and come up with language that would minimize that so patients felt empowered and engaged. And so here's the script we use. I'd like to talk to you about PrEP, a safe and highly effective medication that can prevent HIV. It's recommended for people who may be at risk of getting HIV and want to take control over their sexual health. It's important for all our patients to know about PrEP so they can decide if it's right for them. And we talk about groups that PrEP may benefit. And just to highlight, we tried to include some information about safety and effectiveness, which patients need to make decisions about PrEP. We tried to empower patients. So this is for patients to take control over their sexual health, as opposed to us doing something to them. We tried to normalize this to reduce stigma and judgment by saying it's important for all patients to know about PrEP and let them decide if it's right for them, to again, put them in the driver's seat. We talk about a benefit versus a HIV risk framed set of language, because risk can be alienating to people, and also risk means different things to different people. And we talk about non-judgmental language around things like condoms. We talk about if people don't want to use condoms, PrEP is a good option for them, as opposed to being judgmental that you need to use condoms and you should use condoms, which can be also alienating. And then finally, things that matter most to patients. It's not just about preventing HIV, but about the experience of sexuality. And we know that lots of people benefit from PrEP because it reduces their anxiety about HIV, increases sexual pleasure. And so we want patients to know that may be a reason enough to start PrEP. So one of the things we learned as part of this project is that providers rely appropriately on clinical heuristics that are based on traditional risk factors for HIV, like sexual orientation and STIs. But one thing we learned in piloting this model, we had a provider who alerted us that they thought that the model flagged a patient for a discussion about PrEP inappropriately. And the patient was a 46-year-old cisgender female who was married to a male partner, drinks alcohol, lives in Los Angeles County, and identifies in the EHR as Latina. She had an HSV, or herpes simplex virus, diagnosis several years ago. And so the provider said, this is a misfire. This is not someone who I think would benefit from a PrEP discussion. And that's the question. Should clinicians prioritize PrEP when automated decision support tells you if they don't believe the decision support, then they won't use it and act on it. And so without that trust, it really is dead in the water. And so one of the things we learned here is we have to balance the way providers approach these decisions using heuristics, which are fast, unconscious, and automated mental shortcuts to get the job done quickly, which are often quite effective, but also have gaps. And that has to be balanced with a rational decision-making process, such as this automated prediction model, which is sort of super rational using machine learning. And it's very slow and effortful and complex, but it's quite reliable because it's using objective data, but it's not perfect either. And so one of the things we learned from this about using any kind of decision support based on things like machine learning is that clinicians aren't sort of naturally prone to trust it. But if we use some sort of evidence-based approaches to try and negotiate more trust in the model, that seems to be one way to do this. We pulled some data from OCHIN, and we found out of the over 6,000 new HIV diagnoses over the past years that we used to build our model, only 2.2% of all those people had a prior bacterial STI in their OCHAN EHR record, either a positive diagnosis or test, meaning that if you only bring up PrEP with people with STIs, you'll miss 98% of people. So we think that the best approach is actually not an either or, but an and both. If providers use traditional heuristics to identify someone for PrEP, that's a good thing. But if they also have a flag from a machine learning model that may identify social determinants of health, for example, that people who are Latina may have increased risk of encountering someone in their sexual networks with HIV, even if they have the same sexual risk behaviors as someone in a network of white partners because of assortative mixing. So this is a way of trying balancing all these things to improve the use of PrEP in clinical practices. So a bunch of healthcare organizations are either building or implementing models like this now. The Massachusetts Department of Health is using one of the models we built to try and improve practices across the state. In Duke, they're building a model. In Jefferson County, in Mobile counties, Alabama, we have an NIH supplement to work with them. Also in Louisiana and in Parkland Hospital in Texas. And then of course in Kaiser Permanente, where Julia built that first model, they've already implemented this as well. So it's something that is going to be growing in terms of use. And so further study seems important to make sure it's working. So let me shift a little bit to one of the other parts of the frameworks to address provider barriers that I mentioned at the beginning, besides decision support, is engaging a broader set of healthcare providers. So there are lots of specialties beyond infectious diseases and primary care that could really be well positioned to think about PrEP. So this is just a long list of them. So sexual health, addiction medicine and psychiatry, family medicine, internists, OBGYN, adolescent and pediatric providers, people who work in the criminal justice system, nurses, advanced practitioners like physician assistant and nurse practitioners, and then pharmacists who in the community are all over the country and offer a really great way to think about scaling up PrEP with other organizations. So here's a quote from a qualitative study about why a cisgender woman who identified as Latinx really wanted to think about getting PrEP from an OBGYN provider instead of a primary care provider. Because I talk about my sexual life in detail with her or him, meaning the OBGYN provider, her most of the time. I feel more comfortable doing that. I'm on birth control. I'm on top of my testing. I'm on top of my visits. I feel like it would be appropriate for the GYN to administer PrEP services. So it's an example of trying to meet people where they're at in terms of their preferences. And then in terms of broadening the scope of providers, I think we also need to engage providers at all stages of training, not just when they're fully fledged prescribers, but we have to think about med students, residents, fellows, and then attending physicians who are sort of fully fledged, and think about schools, not just of medicine, but nursing, PA school, NP programs, and pharmacy as well to try and broaden things. And there's some analogies here in terms of reproductive health. This is from the Medical Students for Choice from Howard University, where their website talks about organizing at the med school level to get people excited about reproductive health as they join their careers at further stages. And their mission is to inform students about the different ways to incorporate abortion care into their future medical practices. And so I think there's some good analogies around sexual health and PrEP that can build off these models as well to try and get people thinking about this is an important part of general care, not just some specialized thing that certain people train to do. So the last thing I'll mention is thinking about these alternative settings of care for prescribing PrEP. And I think there are lots of places where people would welcome PrEP outside of these settings. Dr. Hansel Tukes from Miami has done a lot of work with addiction medicine and providing HIV treatment and prevention using virtual care for people who are undomiciled and on the streets in Florida, which has been incredible work. There are people who work in other harm reduction programs that are well positioned to offer PrEP to people who come in for addiction care and for substance use care in general. People who work in the criminal justice system, Dr. Ankh Najawan and I have a R01 called the Hotspot Study, where we're trying to implement a PrEP program in the Dallas County Jail for people as they re-enter the community to know more about PrEP and try and link them to community sites. And community sites are a place that have the trust of people already. And so we have to think about ways to provide PrEP when people come in for general community-based services around sexual health and substance use. Youth programs where youth like to congregate, we should bring PrEP to the programs. Teleprep, which is using virtual PrEP care, has gotten a lot of attention recently. And there's some great research, including by Ken and Aaron Siegler, around a prep at home study, trying to figure out better ways to provide virtual prep care, which we know is really effective for people. And finally, lots of new studies about community-based pharmacists. There are some policies that allow pharmacists to initiate prep even without other clinicians being involved. It's been around in California for a couple of years. Implementation has been limited thus far, but because retail pharmacies are all over the country, including in rural areas, and most people live closer to a pharmacy than a medical center, we have to think about ways to engage pharmacists as well. So my final thoughts before handing it over to Alex: PrEP is underused, clearly inequities exist, and we need to address the multiple healthcare provider barriers to PrEP provision to scale this up. There are evidence-supported strategies already, like academic detailing and ECHO, that Alex is expert at, and we'll talk more about, that we need to expand, and we need to do it now because they already are working, and there's infrastructure. New ideas like prediction models and EHR-based decision support can be helpful to increase PrEP use and impact, but we need to figure out how to do it in a way that providers trust and will actually use. And we need to think about engaging more providers early in their training and late in their training across multiple specialties, and think about providing PrEP in new settings to meet people where they're at. So I will stop there, and I'll hand it over to Alex for part 2.
Thank you so much, Doug. Hi, everybody. Great to be with you all. I'm delighted to be presenting with my longtime close colleague, Dr. Krakauer, and many thanks to Drs. Mayer and Sullivan and the CPAR for inviting us to focus on this topic today. I'm going to be focusing on some applied programs for implementation, capacity building that we've done through our National LGBTQI+ Health Education Center to scale up some of the approaches that Doug was describing, and in many cases has been involved in pioneering and innovating himself. A word about Fenway Health, where the National LGBTQI+ Health Education Center is based, and this is important, as you'll see, in terms of the health systems in which we're doing this implementation. Our education center is based at Fenway, which is now an over 50-year-old federally qualified health center in downtown Boston, which from the beginning has been focused on providing care for marginalized communities, sexually and gender diverse people. Certainly once the HIV epidemic hit in the 80s, that became a primary focus. Fenway is now the largest provider of HIV services in New England. We see over 2,300 people living with HIV in primary medical care each year. It's also the largest provider of transgender health services in New England, seeing over 4,500 trans and gender diverse people. And the largest prescriber of PrEP in New England as well. Ken can give us the latest numbers on exactly how many PrEP prescriptions Fenway has prescribed. He's much more on top of that particular number than I am. But all to say, the health center is a little unusual in that it has an institute, the Fenway Institute, which focuses on research, education, training, advocacy, and policy for LGBTQI+ people, as well as people living with or at risk for HIV. Some of the studies that Doug mentioned were performed at or in partnership with the Fenway Institute. And our education center is based there. We've been funded since 2011 by HRSA's Bureau of Primary Healthcare in the federal government to provide education, training, technical assistance, implementation science, and capacity building across all 1,400 federally qualified health centers in the country that serve over 30 million of the most socioeconomically disadvantaged people in the US and in all 50 US states, Washington, DC, Puerto Rico. We have many resources on our website specifically focused on HIV prevention. I'll talk about some of those today. You can access many more at lgbtqiahealtheducation.org. And we're specifically tasked by the Bureau of Primary Healthcare to help roll out and scale up PrEP across the National Health Center program, which within the federal government's Ending the HIV Epidemic in the US initiative is the primary health system or vehicle through which PrEP implementation is supposed to occur. As Doug mentioned, there's what he referred to as the purview paradox, where infectious disease folks sometimes don't think prevention is within their purview. Primary care folks don't necessarily think infectious disease prevention is within their purview. And really the idea here is that this is viewed as part of primary care, should happen within primary care settings. And that's why federally qualified health centers are ideally suited for this implementation. This is an analysis we recently did out of the Uniform Data System. This is the data set that all federally qualified health centers have to enter key variables into to report them to the federal government. In 2020, the federal government initiated reporting of PrEP prescription counts within the uniform data system as part of the Ending the HIV Epidemic initiative. And they then made some adjustments. 2021 was the first year where this data collection was, the federal government believes, occurring accurately. And this is analysis we did with Doug and Ken and other colleagues, Julia Marcus, who was mentioned, where across over 30 million patients in 2021, about 79,000 patients were prescribed PrEP, which certainly is below the 1.2 million target nationally. But this does mean that approximately a quarter of all national PrEP prescriptions occurred through the National Health Center program, which is pretty remarkable if you think about it. And we also found, this is a study that's under review now at a journal, health centers that prescribed any PrEP had higher proportions of patients who are Black, Latina, or sexually and gender diverse, compared with health centers that prescribed no PrEP. And compared with health centers that prescribed no PrEP, a higher proportion of health centers that did prescribe PrEP were in high priority jurisdictions of the EHE initiative, or states with Medicaid expansion or public PrEP assistance programs. So this really makes the case for funding health centers specifically within EHE priority jurisdictions in terms of bang for our buck with taxpayer federal dollars to really reach patients who are candidates for PrEP with an eye towards meeting our targets for ending the HIV epidemic. This is referring to something that Doug discussed, where we collaborated closely with the Public Health Department in New York City, led by Dmitry Daskalakis at the time, who now heads the HIV prevention division at the CDC. We adapted the PrEP detailing approach that they had pioneered in New York City through our Bureau of Primary Healthcare Education Center. And Doug was involved with this. Kevin Ard, who's a colleague at Mass General Hospital, couldn't be with us today for the webinar, but is the medical director for our education center. We collaborated with the Public Health Department and really tailored their PrEP detailing approach for the National Health Center program and took it from city level in New York to all 1,400 federally qualified health centers across the country, and particularly for primary care settings. This has been widely disseminated. We partner with the AATCs, certainly our AATC in New England, but also several across the country in different regions. And this has been downloaded many times through our National LGBTQI+ Health Education Center website. We've developed a companion to this, which is a teleprep brief based on some of the research Doug mentioned that Ken and colleagues at Emory, where Dr. Sullivan is based, have conducted. And this was by popular demand, since our health centers really wanted guidance on how to implement teleprep approaches. And this was appreciated as a high priority approach by the Bureau of Primary Healthcare for EHE. Now, one of the implementation and scale-up approaches we've adopted is to take this PrEP detailing kit, this PrEP action kit, as we've called it, and use that as the basis for PrEP implementation and scale-up workshops that we've done with primary care associations funded by HRSA's Bureau of Primary Healthcare across the country. Here's the paper that we published on that educational intervention. And here we also did a readiness assessment with the individual staff participants at health centers across the country who participated in the training, in the workshop prior to the training occurring. We ended up working with primary care associations in 15 US states and Washington, DC. That ended up encompassing 29 of the 57 EHE priority jurisdictions with the highest incidence of HIV based on CDC data. So we covered most of those jurisdictions through this one initiative. And there were some interesting data from the readiness assessment. First of all, it was really interesting to see staff's perceptions of how welcoming their health centers across the country were for different populations known to be at high risk for HIV. So for example, there was a significant difference in staff's perception of their health centers' readiness to welcome Black and African-American people and Hispanic people versus transgender and gender diverse people or people engaging in sex work. So this gave us a lead in terms of where there were maybe even larger gaps to make these health centers culturally responsive, inclusive, and welcoming for particular populations at risk for HIV. Staff also reported on their perceived barriers to PrEP delivery. These included patient, provider, and systems level barriers. The most commonly identified major barrier by staff was lack of outreach or engagement for these populations at risk for HIV, whereas leaders identified patients' lack of willingness to take PrEP as the most highly cited major barrier. Leaders were significantly more likely than staff to perceive patients' unwillingness to take PrEP and providers' lack of knowledge about PrEP as major barriers. So there's an interesting difference between sort of the C-suite that may not be on the ground working with patients and communities versus what clinicians and other staff who are directly patient-facing perceive as the primary barriers. We also asked folks what the best use of additional resources would be if there were such resources for PrEP delivery. More resources were available. 56% of staff and 64% of leaders thought establishing a teleprep program would represent the best use of those resources, which is why we developed that teleprep brief for the Bureau of Primary Healthcare that's now disseminated through federal channels. And about 2/3 of leaders prioritized training about inclusive environments for people at high risk for HIV. Both leaders and staff did not think that hiring additional clinical staff members to prescribe PrEP was particularly a priority. So it's not about having more staff, it's about training those staff and building inclusive, affirming environments, as well as outreach to priority populations. And here's a list of the various best use of additional resources and the extent to which these were identified by staff and leaders. Another implementation program that we've led through our education center, again, all this supported by the Bureau of Primary Healthcare, was a national PrEP ECHO program. This is an interdisciplinary telementoring program that we'll talk about a bit for HIV prevention through practice transformation. So it's not just to train individual clinicians, which is often the case. This is really thinking holistically about the health center as a system, as you'll see in a moment. Important to note, as Doug mentioned, there are various professionals, not just primary care providers or infectious disease specialists who need to be involved in PrEP delivery. We were very intentional about requiring for all health centers that participate in this PrEP program that there at least primary medical providers and behavioral health providers had to commit to participating, or the health center had to commit to letting them participate for them to have successful applications to participate in the program. Prevalence of mental health problems among people eligible for PrEP or prescribed PrEP is very common, or is very high. Anxiety disorders, depressive disorders, bipolar disorder, schizophrenia. So it's really important to have mental health, behavioral health clinicians involved as well. ECHO is an evidence-based model developed by the University of New Mexico. ECHO stands for Extension for Community Healthcare Outcomes. The first of these programs actually to democratize specialized knowledge into under-resourced, underserved communities was specifically around hepatitis C treatment. And then there have been many other ECHOs launched over time. Our goals for our PrEP ECHO were to engage multidisciplinary care teams at health centers, medical and behavioral health clinicians, as well as administrators that we require to participate, and to foster organizational and systems level practice transformation for conducive health systems to deliver PrEP. We want to focus as well on priority populations, marginalized populations disproportionately affected by HIV. We had prior experience developing and delivering ECHO programs for LGBTQI+ health with the CDC and with the National Association of Community Health Centers, as well as PrEP, an ECHO specifically focused on transgender and gender diverse health that we've done for many years and had about a couple hundred health centers across the country participate in now. For the PrEP ECHO, we developed a 12-session program for health centers specifically in high HIV burden areas. So these were health centers in EHE priority jurisdictions. And each of these 12 sessions consisted of a 20-minute didactic followed by facilitated peer-to-peer case consultation, where we had a hub of expert faculty, staff at Fenway Health, very involved and experienced in delivering HIV prevention services. And they would facilitate peer-to-peer discussion of cases submitted by participating health centers in each session. Our ECHO faculty included primary care nurse practitioners, primary care physicians, infectious disease physicians, a psychiatrist, and practice administrators as well. We administered a baseline 12-question survey about the practice setting at the health center, clinicians' roles, experiences working with patients with or at risk for HIV, perceived self-efficacy interacting with populations disproportionately affected by HIV, and it featured differentiated questions for both medical and behavioral health clinicians. We had 48 individual participants from 16 health centers across the country in this program. 25 of the 48 health centers were located in EHE priority jurisdictions. So most of our health centers were in EHE priority jurisdictions. 36 were urban, 5 were suburban, 4 were in rural settings. And in terms of individual staff participating, 56% were medical clinicians, 20% were behavioral health clinicians, and 24% had other roles. You can see here that regardless of the number of patients at baseline that were prescribed PrEP at these health centers, that it was a low proportion of participants in most of these brackets of patients receiving PrEP across the health centers, a low proportion of providers who were already prescribing PrEP. So the highest proportion was 55% for health centers that had 1 to 5 patients receiving PrEP. It's a small health center. So there was a ways to go. We were working with sort of a PrEP naive medical provider group at the beginning of this program. And in terms of baseline survey findings, medical clinicians were significantly more likely than behavioral health clinicians to report having cared for people taking PrEP, 91% versus 43%. 43% of behavioral health clinicians, however, had counseled at least one patient about PrEP within the past year. The same proportion provided at least one patient with STI counseling and HIV prevention counseling aside from PrEP, like behavior modification, self-care practices in those areas within the past year. And there was no significant difference between medical and behavioral health clinicians in their self-rated capacity to discuss PrEP with patients, counsel about PrEP side effects, or provide care for LGBTQI+ people or people who inject drugs. Here we see proportions of medical and behavioral health providers who reported above average capacity and skill to perform PrEP-related tasks at baseline. And again, there were no differences between the two groups in this regard. We also collected qualitative responses to questions about PrEP barriers, and people reported lack of knowledge about PrEP in many instances, a need for baseline laboratory studies, need for adequate staffing, need for PrEP navigation services, and questions about how to incorporate PrEP into behavioral health care. These were challenges named at the beginning. This is from one baseline survey respondent. It often feels that in my role as a behavioral health provider, patients do not feel that discussion of HIV and STI prevention is a topic best suited for therapy, and will often prefer to discuss these matters with primary care providers. I'd like to learn tools to more openly discuss this topic with patients, and allow them to feel that this is something that can be assessed with all providers. Here's the didactic curriculum that we developed for this PrEP Echo, separate from the facilitated case discussion that would happen after each of these didactics in each session. We covered standard clinical management and monitoring, PrEP financing, which was a big priority. And I should say for the Primary Care Association collaboration I mentioned earlier, where we would do workshops across the country with the PrEP detailing kit, we would identify in each case locally in that state an expert on the PrEP policy landscape and financing, because we in Boston at our health center, even though we have a national footprint, aren't in each state knowing the specifics of how PrEP is financed or not. So we would work with the Primary Care Association to bring such a local person into the program for each state. So PrEP financing, system level issues and leadership like change management in implementing PrEP, PrEP for trans and gender diverse people, PrEP for people who inject drugs, different models of PrEP delivery, pharmacy provision of PrEP, as Doug mentioned, really important. Teleprep was a focus, PrEP for adolescents, integration of PrEP with behavioral health and substance use disorder treatment, focus specifically in a culturally responsive way on Black men who have sex with men, Latino men who have sex with men, and medical mistrust in communities with experiences of a lot of medical harm. Informatics, a lot of the innovations that Doug talked about that he's led nationally, care for cisgender women specifically, and new modalities and best practices to promote persistence and adherence with PrEP. Across 12 sessions, most participants provided the highest ranking on a 5-point scale in response to a question about each 90-minute session as a whole that asked to please rate how well this presentation met the stated goals and or objectives of the program. Similarly, most participants provided the highest ranking when asked if each session provided new ideas or information they expected to use in their work. And we also asked about both the content and delivery of the didactic presentations, with most participants providing the highest ranking on a 5-point scale for these domains as well. We've just been refunded through 2026 as a National Training and Technical Assistance partner of the Bureau of Primary Healthcare. We're going to be doing more in the way of PrEP implementation and scale up across the health center program, bringing to bear innovations in the biomedical arena, as well as a really rigorous quality improvement program we're going to establish across the country. So we're looking forward to collaborating with Doug and Ken and others in this regard. And I'll stop here and turn it back over to our moderators for discussion. Thank you for your time.
Thank you so much for that presentation, and Doug, for your excellent presentation as well. We're going to open things up for questions. So I would encourage people to, you can either raise your hand, or if you want to ask questions sort of in person, or you can put questions into the chat. I have some questions to get us rolling. And Alex, since you're still on the screen, maybe I'll start with you, and then we'll bounce a question to Doug after that. In terms of the sort of survey responses about why there's a lack of willingness to take PrEP in certain settings, you noted these divergent perceptions among providers and leadership. Are there ways to address those leadership concerns about lack of willingness to take PrEP? Like, would local survey data from their clinic be persuasive, or do you have any sense of whether, like how to reconcile when you have these different concerns?
Yeah, I'm happy to start briefly, and I think Doug will have some thoughts about this as well. It was really interesting to collect those readiness assessment data right before we did these workshops, where we ensured that it wasn't just patient-facing staff, frontline staff who were participating, but that we had executive leadership within the organization as well. So this dialogue between, it was striking what a kind of disconnect there was, and to facilitate more communication there for these leaders to hear from staff interacting with patients and communities about what the barriers were, I think did facilitate some change. And that's why we focus on this organizational practice transformation approach in subsequent programming like the ECHO, as opposed to just having conversations with patient-facing service delivery staff. Doug, do you have thoughts about how we can bridge that gap?
Yeah, I think it's a great question. I agree with what you said. It's almost like you have to have these intentional discussions, almost like marriage counsel. Like, let's put the executives and the frontline people in the room and, have an open discussion, from each person's perspective, what they think are the facilitators and barriers. And then sometimes you discover things you didn't even really know. And I sort of wonder if there's a lot of heterogeneity even amongst individual providers. Some providers are more motivated and interested in these topics, and others will feel like it's way out of their zone. And so having a safe space where everyone can kind of say where they're at, and then what interventions will get kind of the leadership, depending on where they're at on the scale of readiness and interest, and the frontline people all moving forward in the same direction, I think, is one way to go about that.
Great. Thanks. Thank you, Doug and Alex, for that answer. Doug, I have another question for you that came in from the chat from Jim Pickett. How do these decision support tools align with updated CDC guidance that suggests that all sexually active people learn about PrEP, and then anyone who's interested could be offered PrEP?
Oh, that's a great question, Jim. And it's sort of going the perfect not being the enemy of the good here, in the sense of the ideal is clearly for clinicians to bring up sexual health and PrEP with all sexually active adolescents and adults, just like the CDC says. There's no question that would be the best way to do it. And these tools are like a stopgap measure where we know that's not happening. It's not imminent, and we're not even remotely close to that. So the goal here is to help providers think about which subset of their overall panels can they prioritize PrEP discussions in. We know we'll miss some people, but we'll probably catch a lot more people, hopefully, that otherwise these discussions wouldn't happen at all. And then over time, as clinicians get more comfortable with bringing up sexual health and PrEP, and they get that kind of muscle memory, then the goal would be to encourage them to weave this into their routine counseling. I think some examples from reproductive health and contraception are good, because a lot of providers in primary care do feel comfortable asking about what are your contraceptive practices in a more general way. And it's just part of their A to Z for their annual wellness visits and things like that. And so ideally we get PrEP into that rubric of how they do this. And these decision support tools are a way to prompt providers to do more of that before that becomes the case. And also just the practical steps about ordering labs and meds and stuff, making it one click is so much easier than asking a provider to pull up a training slide set at the point of care and figure out like which labs you have to do and which dose of Truvada and this and that. I think just making it, one button and you're done is the goal there. So I wish we lived in a world where we didn't need any of this and everyone would make this routine, but I think having this intermediate step is one way to go.
Great. Thanks, Doug. There's another question from Mary McKellar that I think might, maybe we'll ask Alex to start with, and Doug, you're welcome to weigh in. But Dr. McKellar said it's interesting that cost and insurance aren't coming up as barriers for either providers or leaders. Was this some sort of survey that had a list of possible options that didn't include that? Or maybe these are the kinds of settings where the costs are being subsidized by the clinics. Any thoughts about why that didn't come up as a barrier in these assessments by providers and leadership?
Thank you for that question. And as it actually absolutely came up, I hope I didn't suggest that it didn't. And I can share screen here to just provide those data that were in our supplement for that paper that I showed. Let me see if this is it. I believe this is it. Yeah. So this is from that readiness assessment that we did. And as you can see, there were often concerns raised about lack of health insurance being a problem, high cost sharing for insured patients, reimbursement for PrEP care, capacity to link patients to financial assistance for PrEP. So major barrier across the board, absolutely, in various ways. And this is why we ended up in the program that we developed based on this readiness assessment and in our PrEP action kit, certainly focusing on PrEP financing and the intricacies as a huge problem. Ken and I are involved in an HPTN funded study where we're doing PrEP echo specifically for intersectional stigma reduction among Black MSM at risk for HIV. And we're in that case, once again, doing what we did here, which is to engage experts at the state level on PrEP policy and financing to really understand the landscape, to work with specific health centers from each of the states participating, like in Georgia, for example, and elsewhere. So that it is consistently a major barrier and concern raised by health center staff. Thank you for asking.
Yeah, thanks for that, Alex. I think in looking at the whole table, it seems like you highlighted a couple where there were divergent views, but that was one where there was agreement. So thanks for that clarification.
Yeah.
Doug, this question came in during your talk. Had you thought at all about positive versus negative framing? So what people would gain by being on PrEP versus what they would lose, like anxiety. So any thoughts about positive or negative framing of messaging?
Yeah, it's a great question. I think positive framing is probably the way to go. There's some data about that in terms of, I was mentioning a little bit about how the term risk can be alienating and stigmatizing. And also I think some people don't perceive themselves at risk for something that's still relatively uncommon on the population level, like an HIV diagnosis. And so there's a great campaign that's associated with the rollout of injectable PrEP called From Risk to Reasons, which was organized by, I think, ViiV, and also a group of Black women who are really trying to think about the community perspective in terms of how you frame PrEP. And I think it's a really great campaign. And in switching the conversation about risk of HIV to reasons to benefit from PrEP, because that's why people do things. That's in terms of the behavioral science, that's what would motivate people. In some cases, it's to avoid a negative outcome, but I think a lot of people, it's to think about the benefits in terms of their sexual pleasure and empowerment and feeling confident in their relationship. So I think all the provider trainings ideally would acknowledge this as part of the training, about asking providers to think about the language they use and actually how they approach this in their own minds in terms of how it's framed. So I think it's part of the puzzle for sure.
Great, and I'm gonna have one last question, which was specifically tagged as not a question, but I think it would be great to bring this to light and to get your comments. So Joanne Steckler, thank both of you for your great presentations, and just made a comment about detailing. She said they started a virtual program during the pandemic and recently discontinued it because of poor uptake. Great for one-on-one training, but a lot of FTE for little impact. So are you aware of other, what other ways, or are these the right or main ways to evaluate the sort of bang for the buck, and have other programs had similar evaluations?
Thanks, Joanne, for mentioning that. I think I'd love to talk more with you to hear about your experience with the detailing. I think that, over the long haul, academic detailing, including the New York City campaign, and across other areas of medicine, has a very strong evidence base. There was a Cochrane review a bunch of years ago showing that it's one of the strongest evidence bases for changing providers' prescribing behaviors. But I do think that it's a resource-intensive intervention. And it's also, I think, PrEP in terms of the ask for providers is a high bar in terms of the detailing. I mean, a lot of detailing was prescribed this generic proton pump inhibitor instead of this brand name medication to save money. And so it's a very simple change in behaviors, whereas PrEP, for a lot of people, the detailing campaigns have involved the basics about how you talk about sexual health, and it takes a lot to get to the actual prescribing piece. So I think that I haven't heard of programs being formally evaluated to the degree that maybe you would be able to, and most of them are kind of rolled out as programs, but not necessarily quantitatively evaluated. So I think it's an important area so that we can figure out if the juice is worth the squeeze and in what settings. Alex may have more thoughts as based on the NEATC detailing campaign.
Yeah, I mean, I agree with everything Doug said in terms of the ECHO piece, which was the first part of your question. Would be happy to connect. You express some interest there. We're just relaunching this year. We don't have an exact date yet. As part of our new 3-year cycle of our cooperative agreement with BIPIC, we are required to kind of fill as many spots with federally qualified health centers as possible, given that that's what HRSA is supporting. That being said, we can kind of, once we take all the health centers that apply that are viable, include other types of health systems as well. So please feel free to be in touch about that.
Great. Well, I want to thank our speakers again, and thanks our colleagues at Harvard CFAR for their leadership of this. I want to remind you that the next AFP session will be jointly presented by Monica Gandhi and Adi Rana from UAB, scheduled for October 2nd. And please look for scheduling emails. Hope everyone has a great rest of their day. And thanks again to our speakers.
Thank you.
Thank you.
Thank
That's
you.
great. Thank you so much.